Hey you guys, I'm just going to go over the equipment you'll need for intubating LMA, otherwise known as fast track. So this is what a normal LMA looks like. You can see it's pretty curved. You just put it in and then it allows the patient to ventilate, but there's no intubation involved. With a intubating LMA, you can see that the angle is much more steep and it allows for the ability to have the ET tube basically be placed in here, an oral ET tube be placed in here, and then you do kind of a switcheroo method that I can show you later, where you can pass the oral ET tube and simultaneously remove the intubating LMA out. So that way you can actually intubate the patient this way. This is a stabilizing rod. This is an example of an oral ET tube. There's a syringe that you'll need as well as some lubricant. And then this is a cap that you'll need later too, and I'll demonstrate how to do that. To prepare the equipment ahead of time, the same way for a normal ET tube, you'd want to verify if there's a leak. So you just kind of inflate with the syringe, it looks good, and then deflate it. And then you'll also want to make sure you have some lubricant, and you can put it on the oral ET tube, because sometimes it can get kind of stuck or difficult to pass when it goes around the corner. You also want to put lubricant on the back side of the intubating LMA when it goes in a patient's mouth. All right, I'm just going to show you guys how to place the fast track LMA. I'm going to do it with one hand. It's basically the same way you'd put a normal LMA in. You bring it in like this. You follow the curvature of the palate, and as you curve it inward, it should, this is a mannequin so I have to encourage it, it should sit comfortably like that. I want to briefly mention in here, but there's something called the Chandy method or maneuver that is used to help facilitate kind of the oral ET tube placement, and as well as being able to place the fast track in a good position. So the Chandy method, there's two parts. The first part's when you first place it and try and figure out the best place to ventilate, you can kind of move it left or right, or up and down a little bit, just so you can kind of find the best position when you're doing the ambu bag to ventilate. Later, when you're about to put in the oral ET tube, it's recommended that you do kind of a lifting motion, not tilting, but you kind of lift up. And in that case, it will allow easier passage of the oral ET tube. After you place it, you want to confirm the ability to ventilate by having both lungs expand. And it's hard to see, but the bilateral breath sounds can be heard and chest rise can be seen. This is the oral ET tube that I mentioned before. I already put some lubricant on it because sometimes it can be kind of hard to pass through, but you put it in. Normally I'd have both hands, but alas, I will try to do this one-handed. Put it in until about the same depth as the normal ET tube. Sometimes you'll have to have both hands to manipulate the fast track positioning to make sure we're positioning it to hit the trachea and not the esophagus. So I will do that in a bit. I manipulated it some more so that you can see the oral ET tube is actually placed inward more. The next part is going to be the switcheroo method, which basically I'll be using the stabilizing rod. You place it at the end of the oral ET tube while simultaneously removing the intubating LMA and keeping the ET tube in place. This is what I call the switcheroo method, but I think there's a fancier name than that. This is something I'm not very good at, but essentially I'll show you how to kind of do it. All right, so I want to attempt to do the switcheroo method. Right hand with the stabilizing rod, don't move that, while simultaneously trying to remove the intubating LMA. I'm always paranoid that the oral ET tube is going to come out. So go carefully. You do this until you can grab the oral ET tube. And when you can, then do that. This cap is super important. you put it at the end of the oral ET tube. Maybe. Okay. Put it at the end. This is the only way to connect it to the bag and boot bag that we'll be able to check if it's in the right place. And hallelujah, both lungs are inflated. I'm in. That's how you do a fast track or intubating LMA. I'm just going to be talking about nasal intubation indications, such as when the oral ET tube would be obstructing the surgical field. Certain surgeries, like a temporal mandibular joint surgery, a Lefort 1 or 2 osteotomy, incision and drainage of severe oral facial infections, and an intermaxillary fixation surgery would be indicated for this. I'm not quite sure what these surgeries are yet because I haven't seen them, but looking forward to it. You can also use a nasal intubation if the surgeon prefers that, and of course if there's a difficult airway involved. Contraindications to using a nasal intubation is of course if there's a basal skull fracture, there's a maxillofacial injury, for trauma patients where the mechanism of injury suggests a facial fracture, if the patient has a bleeding disorder or is on anticoagulation therapy, and if there's an infection in the nasal cavity. I'm just going to start talking about some of the equipment that you'll be seeing for nasal intubation. This is a size 7 nasal ET tube. You can see it's shaped differently. It has more of a curve there, and it's just based on the anatomy so that it'll be able to stay put after we do a nasal intubation. Just like for other ET tubes, you want to check for cuff leaks, so you inflate that ahead of time. And yes, so you'd also want like a nasopharyngeal airway close by just in case they need it. You want some lubricant or vasoactive nasal spray to help with kind of vasoconstriction, and also for the lubricant to help with the passage of the nasal ET tube down. To help kind of make the nasal ET tube more flexible, you can also have warmed saline or distilled water that you can put the nasal ET tube in so that it makes it more pliable when you actually use it. You want a straight connector to be able to attach that to the ventilator after you're done intubating. And one of the things that we'll be using will be this is the McGill's forceps. It will be helpful in trying to facilitate the insertion of the nasal intubation, which I will show in a bit with a friend. So these are just some of the equipment that you'll see us use for a nasal intubation, among other things not shown here. When you do a nasal intubation, the same steps apply when you're doing an oral ET tube. You obviously do direct laryngoscopy in order to visualize the mouth. One difference though is after you place the nasal ET tube as far as you can go, your right hand, instead of directing this, will be in charge of the McGill forceps, which you will be careful not to, when you grab it in the mouth, don't grab it to the cuff. Then that could cause a tear, and then the nasal ET tube would be useless. So you want to be sure to grab it somewhere above the cuff area. You would have an assistant who would then be in charge of moving this forward and pushing it forward as you help to direct the where it would go, and hopefully aim it towards the vocal cords. So someone else pushes and you maneuver it up, down, left, or right. And that's going to be the tricky part of being able to communicate with other persons so that we do nasal intubation. So when doing a nasal intubation, before you insert the nasal ET tube, you want to put lubricant on the back side of this so that sometimes it can be hard to facilitate the passage of the nasal ET tube into the patient's nose. So it's helpful to have lubricant. And when you insert it, you want it perpendicular to the patient. So you put it in a little bit, maybe about there. And you don't want to accidentally intubate them in the esophagus. So to help visualize the vocal cords, you want to use direct laryngoscopy. So you put the blade in your left hand, and then in the right hand you'd have the McGill forceps. So I would have an assistant come and she will help to push the nasal E tube forward when I say so. So it's really important that you have good communication between each other. So I'm going to be visualizing. I see the vocal cords, and I will be careful not to grab the cuff or the uvula, because it can be, the McGill forceps can really damage that. So what I want to do is push. Okay, stop. Then I'll grab it again. Can you push? Okay, and push all the way. You're in. Sweet. So obviously, to confirm, we're going to do smells, which is S will be when we attach it to like a bag or the ventilator. We're going to see chest rise. We'll see mist in the ET tube. See end tidal CO2. Listen to lung sounds on both sides, and see O2 saturation. And that's essentially how you do a nasal intubation.
Certain indications for using a fiber optic bronchoscope, otherwise known as a FOB. You can use it when a patient is awake or asleep. To use it when they're awake, they'd have to be a difficult intubation reviewed by the H&P, or if they have anatomic or pathological factors involved. There's an upper airway obstruction, like a tumor, abscess, or prior surgery. They have a subglottic stenosis. That they have a congenital upper airway abnormalities, such as Down syndrome, Pierre-Robin syndrome, Turner syndrome, etc. If they have an immobile cervical vertebrae, they're at severe risk for aspiration, or they're hemodynamically unstable. If they're asleep, indications for an asleep fiber optic bronchoscope is if it's elective, if you want to confirm a position of a double lumen ET tube, and if you want to evaluate the airway edema. Contraindications to using a fiber optic bronchoscope include heavy secretions or bleeding of the upper or lower airways that's not relieved by suctioning. There's an inability of the patient to cooperate. There's hypoxia, and if there's an allergy to local anesthetics. Just like with everything we do in anesthesia, there are possible complications that can occur with placing an FOB. The most common emergencies include laryngospasm or bronchospasm with inadequate depth of anesthesia. If you can't visualize due to a lot of blood or secretions in the airway, and if there's a failure to thread the ET tube over the bronchoscope.
Meet Billy. This will be who will be doing a fiber optic bronchoscope on. Before we prepare, you want to make sure you have suction available, that you have an appropriately sized FOB or fiber optic bronchoscope, as well as a appropriately sized oral ET tube or nasal. I have an oral ET tube there, 7.5. You want a light source, which typically comes with the fiber optic machine. I just turned it on to make sure it was working, and I'll be able to show you kind of how to use that in a bit. There's something called an ovosapient airway, which is the pink thing right here. It helps to center the fiber optic bronchoscope when you're using it, and it's so much easier to have this with you when you're doing this. I'll show you kind of the difference. But basically, this keeps it centered, and it allows you to find the vocal cords a lot easier than if you were to manipulate it by yourself. You can make sure you have IV anesthetic agents, as well as the checklist says a stepping stool if needed. But I think I'm tall enough that I don't need a stepping stool. But for the short people out there, make sure to get a stepping stool. Before you put a fiber optic bronchoscope down the patient's mouth or nose, you want to make sure, first of all, you set it up where the ET tube or ET tube or nasal goes in first. That way, makes it easier. Once you reach your target, the carina, you'll easily just kind of slip this down into the appropriate spot. Another thing is you want to see if the patient needs something for basically drying up the secretions. If they have a lot of saliva, it might be difficult to use a fiber optic. And here's that ovosapient airway that I mentioned earlier. That's super helpful when you're placing this and keeping it centered. I'm going to do a better job on showing you guys how to do this, kind of control the movement
of the fiber optic as it goes down. So here is the tip. If you imagine with me, you move your thumb down, goes up or towards me. If I move my thumb up, it goes down or away from me. Essentially, it's just opposite. So just think down, up, down. And like I mentioned before, that's how I use controlled up and down movement of this. To control the left and right movement, it's relatively simple. With your right hand, you would move this to the right or left, depending on the view that you want to see. And if you look at the screen, you can see that it's moving left and right, up, down. And if you get good at it, it's kind of like playing a video game when you have to do 2 different types of motions at the same time. And that's why it's kind of fun.
I'm just going to have you guys kind of focus on the screen while I get ready to manipulate this. So, as I mentioned before, the ovosapien airway, I'm actually going to place that in real quick. Place it in like a normal airway. See? So I'm just going to start going down, go in through, and I try and visualize the vocal cords. So I see right there. I'm going to go through. And I see the CRNA. Right there. Success. Yay! Okay, let's say we just place the ET tube. As we move out the fiber optic, you want to be able to visualize, okay, there's the cuff. Very good. We already saw the CRNA earlier. See vocal cords. And we are out.
If you're going to be placing a needle cricothyrotomy, there are relative contraindications for it, including if you're working with pediatrics less than 6 to 12 years old, if there's a laryngeal pathology like a fracture or neoplasm, there's subglottic stenosis, coagulopathy problems, distorted or unidentifiable neck anatomy, restrictive lung disease, and obesity. When we place a needle cricothyrotomy, we'll be using something called a transtracheal jet ventilation, and there are possible complications of using this, including barotrauma, subcutaneous emphysema, pneumothorax, pneumomediastinum, hypercarbia, which can lead to respiratory acidosis, esophageal puncture, soft tissue damage, bleeding, aspiration, catheter kinking, and inadvertent removal of the catheter.
I want to be talking about the equipment for a needle cricothyrotomy as well as a surgical cricothyrotomy. It's also known as cric placement. So for a needle one, you want a 3 ml syringe. You'd want like a 14, 16, or 18 gauge IV catheter. Obviously, you'd want the cric kit. You'd want some sort of ETT connector like that cap. And later, you can have transtracheal jet ventilator if that's available to hook up to the patient so that they'll be able to help breathe for them. For a surgical cric, you want a mini scalpel, some tie straps, like some sort of a dilator, airway cannula, and there's also a guide wire, but unfortunately I was unable to find one. But you can imagine the wire just helps to do kind of a switcheroo method later, which I can verbalize when I show you how to do these. So these are just some of the equipment that you'll find when you're doing a cric placement. So when you first start to place them, before you do a needle cricothyrotomy, you want to make sure they place the head in a neutral position. You connect the 3 ml syringe with the IV catheter, like this. And then you have to identify the cricothyroid membrane, because that's going to be where we're going to
poke them. So I feel the thyroid and the crike. There's a soft spot right there. You can also see there's a lot of holes right there from previous attempts. So the cricothyroid membrane's right there. So when you place the needle, you want to basically place it in a caudad position, which is going towards the feet. And when you go in, do it kind of at a slight angle. You aspirate for air, just making sure that you're in the trachea. If you see air, that's good. And if you see blood or other stuff, might not be in the right place. So when that's done, I would have 2 hands for this, but you'd remove the needle. And it's really important that one hand, usually your non-dominant hand, should always be with the catheter, because it could, if it gets dislodged, then the effort was in vain. We usually have one person in charge of holding the catheter in place at all times.
Indications for doing a surgical cricothyrotomy is if you want a more permanent means of ventilation than what the needle crike can afford you. There's traumatic injuries of structures that make oral or nasal intubation impossible or difficult and is too time-consuming, such as maxillofacial structures, C-spine, or head or neck trauma. If you want immediate relief of upper airway obstruction, and if you want a definitive airway for neck or facial surgery when intubation is not possible. The relative contraindications and possible complications of a surgical cricothyrotomy are actually very similar, if not the same, as the contraindications and complications of placing a needle crike. So I won't go through it for the sake of time, but you can review that from when I talked about needle crikes earlier.
So at this point we have the catheter placed in. We could keep it like this, and this will be a needle crike. You attach it to transtracheal jet ventilation and then go from there. If you want like a more secure method for doing a crike, then you switch to a surgical cricothyrotomy. So you keep one hand on the catheter, like I said, at all times. I don't have a guide wire, but imagine with me there was a guide wire. You place it through the catheter, and then when it's in the right place, you then would switch out the catheter with the guide wire. I call it the switcheroo method, but it's actually the Seldinger's technique, so that's the official term. So imagine a wire goes down, you move the catheter out. Obviously the wire is still maintaining the position, so we didn't lose the hole that we just made. We would then put in a dilator through the wire, and then before we go down, we have to make the hole bigger. So we have a scalpel. You would make an upward stroke, kind of where the guide wire is, and make a vertical stroke. That helps to make the hole bigger, so that you can then put the dilator through the wire, quickly dilate it, open it up, move it out from the wire. Then at this point, you have the airway cannula that you could place over the wire and down inside and secure it. Then when that's done, you have these straps, these little tie straps, you can place on each end, tied around the neck, and that would be a surgical cricothyrotomy. And one way that it makes it more secure is because it's not only a bigger cannula going in, but you also secure it with the tie straps. So those are 2 techniques you can do for advanced airway management if you really can't do anything else. This is a pretty big emergency that would have to happen for you to be able to do this, and you just hope and pray that you never have to get down the algorithm to get to this point, but that's how you do it.